fast, have no financial interest. So as we all know, glaucoma is the leading cause of irreversible blindness worldwide. And the importance of identifying glaucoma cases is equally important, especially in the remote areas where conventional perimetry is not readily accessible. So the HFA-24-2 CETA program is widely accepted in patients with glaucoma and is considered as a gold standard. However, it is expensive, mainly for some general practitioners, not portable. A data export is needed for the analysis. There is definitely a learning curve for the beginners, and it is difficult for those with mobility issues. There comes the relevance of Melbourne Rapid Fields. It's kind of an amalgamation of technology with science. It is the first iPad-based perimeter in the world. The purpose of the study was to compare the results obtained using MRF and HFA-24-2 CETA fast in glaucoma patients. And this is the first study in South India as a part of a major validation study undergoing worldwide with an exclusive study population of Asian origin. It's a cross-sectional observational study. These are the inclusion and exclusion criteria. This is a numerical scale when you compare MRF on the left side with 24-2 HFA on the right side. So you can see there are few extra points in the central 10 degrees in the paracentral area on the MRF. So cumulative 66 points are analyzed in MRF, whereas 56 are analyzed in the HFE. So the suitable iPad models are any iPad with a 9.7 inches or more. Initially it was designed only for Apple products, but now it is available in Android products also. The software license is around 20,000 Indian rupees, and the test package comes in a multiple of 80 to 100 tests for around 20,000, and this definitely is a cost effective, and the price may vary based on the type of practice. Now the test has to be performed at 33 centimeters for a 9.7 inch tap. So if you are doubtful about the patient position or head movements, you can use a viewing shield, which is optional, and the response is documented by either tapping on the keyboard or by tapping the touch zone. There is a web-based software which is available now. I'm doing a study on the same with which can be done even on a desktop PC or any personal laptops, and there is an offline option also which will be useful in the remote areas. So the protocol used here is a Bayesian protocol, different from the bracketing strategy in CETA fast or CETA, and it covers 30 degrees horizontal and 20 degrees vertical. The initial normative database included 400 people living in Australia, with out of which 35% were Asians. So this is how it looks like. Initially you have to log in like any software app. These are the tests available. Here we have used full test, that is a radial pattern. The fixation point comes in the center, and there will be stimulus displayed elsewhere. So you can either touch on the tap zone, or you can use a keyboard spacebar. Now if it's a small screen, the fixation point moves to all the four corners. If the screen is big, then if it is more than 12 inches, then there will be only one fixation point like in an HFA. And to counteract the tangent effect of the flat screen, the stimulus size increases towards the periphery. This is a printout. It's almost similar to an HFA printout. The only difference is the VFI is named as visual capacity here, and the GHT is replaced by a color-coded indicator. These are the outcome measures. These are the statistical methods used. So 30 eyes of 30 patients were included with a mean age of 62 years. ESD, visual field index, and test time were almost similar. However, there were significant differences in mean deviation, foveal threshold, and points on PSD probability plot. Out of 26 cases which were diagnosed as outside normal limits in HFA, only 22 were diagnosed as red in MRF, which points the possibility of missing some early glaucomatous defects. Reliability indices showed no significant difference. There was strong correlation between the parameters on both the programs. So the test time of MRF was almost similar to CETA fast. Definitely it is 1 to 2 minutes lesser than the CETA standard. The lower MD with MRF could be due to difference in the number, size, location, and duration of stimuli, and the difference protocol used, and difference in the normative database. VFI and VC were almost similar, and definitely the significant lesser number of points with MRF point towards the possibility of missing early cases of glaucoma. Blind outline plots confirmed lower MD and few test points, and this could be due to variation in the study group or participants. So MRF is definitely easy to perform. It's cost effective for a general ophthalmologist, device independent and portable. Data can be exported and multiple tests can be performed at a time. However, yes, it has its flaws. So a definite effective tracking system is not available now for monitoring fixation loss. That should be made available, and inclusion of more regional languages would be useful. So it's the first study in South India with an exclusive study population of Indian origin, comparing more perimetric parameters and identifying new aspects or limitations. And definitely it has a limitation of a small sample size now, but we are increasing the numbers as a part of a major validation study undergoing, and it's a cross-sectional design. To conclude, despite using a completely different program, MRF provided reasonable outcomes to HFA. It is definitely cost-effective, time-saving, and user-friendly, and will be better for community settings as a screening tool, where you can actually refer the cases to a glaucoma specialist for further analysis. Even though some early glaucoma cases may be overlooked, detecting moderate to advanced glaucoma at a fraction of the cost in a remote community justify its further refinement and use. This is no way a replacement to the gold standard HFA, as it's a new technology. We have just compared the thing with the gold standard HFA. Thank you for your kind attention.
It will be better if you have Indian eyes in the database because it's Asian.
Yes, sir.
And
Actually,
so Asian is actually, the Mongoloid population, so to say.
Yeah. So actually, when I asked the manufacturer, so what he said is like in Australia, they had a few Indian population also, but still the numbers are very low. That is why what we are doing now is trying to validate it with more number of Indian eyes. So initially in 2019, we have done a pilot study when I was in Delhi under Dr. Harsh Kumar, and that was comparing with SIDA standard. But at that time, the software had many flaws. Like there were a lot of things which were not available. It was not available offline. So they had a lot of issues with the software, which they later updated. So since last year, we are trying to get more patients to see whether we can validate. So definitely we need more numbers from Indian eyes.
And also the display has so much of variation. For example, even if it's a 9.7 and above to a screen, each pixel will be a little different. Then how do you compare between,
Yes,
let's say,
actually,
desktop version to a iPad version? And how do you get the
so actually
continuous?
the whole viewing distance, everything changes with the size of the
True.
monitor.
Yeah, yeah.
So in this study, we have used 9.7 inch. That is why the fixation point moves to the four corners. So if you have a desktop screen, or the more bigger it is, then the more it becomes like an HFA. There will be only one central fixation point. The only issue is it is not a bowl. So to counteract the tangent effect of the flat screen, what it does is the stimulus size starts at 2 in the center, then towards the periphery it increases. And another issue is the background luminance, but the engineering or the manufacturer says they have actually made it in such a way that it is basically the contrast ratio between the background and the stimulus is what matters. So, and whatever results we got, other than missing some early cases, it definitely worth using as a screening tool.
The other thing is like the ambient, apart from the system lighting, the ambient light also plays an important role
Yes,
in the
actually
room.
it should be done in a dim lit room, and the screen should not have any reflection. So it should not be done near a window where there will be a reflection on the screen. So the screen should be devoid of any reflections, and it should be done in a dimly lit room. That is why there is this option of a viewing shield also. So if you want to use that, then it becomes more easy. But the problem is again the patient has to bend the neck. That is sometimes difficult for some patients. So yeah, the ambient light is a factor. Though there are studies which say like there is no difference between dark room and light room, we personally felt dark room is needed.
So do you have a separate room to do this?
No, ma'am, we do it in our perimetry room only. So it will be dark. So, and if one of the OPDs doctors are not there, then we can use the same desktop PC also. That is a different study, like it is a web-based software. Here we have used
But
the
then you
iPads.
said no illumination. So in the desktop, in the OPD, you have to make it dark,
Yeah,
right?
yeah, we have
The
to close
illumination
the
should be the
windows.
same everywhere
Yes,
if you
yes,
compare, right?
yes, ma'am, yes, ma'am.
And second thing is, you said you did a pilot study. Is it
Yes,
with the latest version or with the earlier version?
No, it is the earlier version. It was done in 2020.
Okay.
That was just
So
28
there
eyes.
is no validated data for the Indian eyes as such. Or
No,
this
ma'am.
is the
No, ma'am.
validated.
Yeah. So I think RP Center, Dr. Vinay sir is doing one study parallelly. So he has done in few pediatric eyes. So pediatric eyes he has published, and it is almost reasonable outcomes. But adult eyes, we are on the process. We are just collecting more data so that we will see whether it can be validated. Till now, we are not very sure about it.
So maybe you should have an age match control also.
Yes, ma'am. Like
For the
in this,
normalize.
yeah, we have a definite control for normalize also. So here I have just included glaucoma patients, but
Exactly.
otherwise, and even mild, moderate, severe, we are actually classifying. But the one issue which comes is the Anderson criteria is actually applicable for the HFA. So we can't actually put the same criteria for MRF and term it as mild, moderate, and severe.
That's
That
because you have rechanged the design of the layout.
Yes,
Yeah,
sir. Yes, sir.
that's
That
because
is
you have
one,
put the spots all over the places.
exactly,
So you
sir.
cannot put the Anderson's criteria there.
Different
So
protocol also.
Yeah.
Moving all over.
the other thing is your brand element. You're not told what is the confidence interval. It's all over the place. Actually, it's quite
Yeah, it's
wide.
actually
Up
the
to
mean
20.
deviation and the number of points on PST probability plot, it's actually very wide.
Yeah. So
So
even otherwise, the uh, the intervals are quite.
yeah, there are outliers also,
Yeah.
the significant
So
outliers.
the issue with this is, I think, the sample size.
Sample size, yes, sir. We need to
Sampling is,
increase more numbers.
Yeah. So this
So
even the
that only
published
becomes
ones are very less samples.
less samples, yes,
28,
sir.
30, something
sir,
like that.
yes,
It's not going anywhere actually.
But
All the
now
pub-
there initially there are a lot of issues, ma'am. Like this, they are told the viewing shield is mandatory. There was no web-based software, and there was no offline methods. And but once we told these suggestions, they have included a lot of things. They have tried to
If
change
you're
a lot
making
of
so
things.
many things, then the idea of doing it at home, it's defeating the purpose. Then you have to have
Yes,
it in a
you
monitored
have a
way.
lack of
Then
support.
yeah, then you have to compare it
For
with.
fixation loss, what they say is they are actually checking the blind spot in the beginning with the stimulus, but still it's better if we can
So
actually
you should have a
monitor it.
tracker.
Okay,
Thank
thank
you.
you.
Thank you. Thank you.